Hello, I'm here during the lunch rush with Janice, who owns her own food truck.
Best cheesesteaks in town.
Janice traded up to Geico Commercial Auto Insurance for her food truck business. We're here where she needs us most.
They sure are.
We make it so easy for her to save, with customised coverage that grows with her business. Sorry, I just get so emotional talking about saving folks money.
Not this onion I'm chopping?
It's just so beautiful. Oh yeah, no, it's the onion.
Get a commercial auto insurance quote today at geico.com and see how much you could save. Get more with Geico.
Welcome to Busy Mom Talk, real talk for real moms. I'm your host, Kia, mom of two. So if you're juggling kids, coffee, and chaos, you're in the right place. Let's get into it. The information, opinions, and recommendations presented in this podcast are for educational purposes only, and every individual should seek medical advice from their own medical professional regarding their medical status.
So for vitamin K, because I think that this is so controversial, and I know so many people who swear they would never give their baby it. Some people swear they would never go without it. Like, why is it so controversial? Is it truly necessary? Like, what is it about vitamin K that medical systems are so adamant about?
Well, this is a good question to have right now because there's this very popular influencer. I have no idea how she got so popular, who just put out a video recently about how the risk of vitamin K deficiency bleeding is 1 in 60.
I've seen that. That's what I was going to ask about.
Everybody's seen that video now. She's always wearing a surgical hat too. I don't quite understand why these. I guess it's like costuming.
Yes.
Right. I mean, I got my T-shirt. I got my good middle of the night T-shirt on, so I guess I'm guilty of it too. But well, let's talk about vitamin K. You have to get back to whether or not you trust nature's design. Because if nature thought vitamin K was necessary for newborns, then nature would have figured out a way for vitamin K to be manufactured in newborns or be transferred from the mother across the placenta to the baby in adequate amounts to affect the clotting system in the proper way. But nature didn't do that, and nature isn't stupid. So maybe if we take a step back from our egos and think that, well, maybe for most babies, having low vitamin K is maybe beneficial for the first week or so until your gut bacteria kick in and start making vitamin K. I mean, if you look at the Jewish ritual of circumcision, it's done on the 8th day of life. There was a reason for that. I mean, part of it, I was taught that they wanted to make sure the baby was going to survive and stuff like that. But isn't it coincidental that that's about the time that baby's own production of vitamin K? So when you're going to chop off the foreskin, the baby has better clotting mechanisms. I don't know. But the kosher laws and things like that in Judaism are actually fascinating. But not part of our conversation today. But nature has a design. So what is this? What is the worry? Well, the worry is something called vitamin K deficiency bleeding. All right. And there's an early onset and there's a late onset. The early onset is almost always caused by medications that the mother or baby are taking, generally the mother. Like seizure medication is a common thing that you might see that. And this is where the indication, where that influencer said that it's 1 in 60. If you look at the CDC results for vitamin K, early onset vitamin K deficiency bleeding, it's 1 in 60 to 1 in 250. So she's even being a bit disingenuous by choosing the 1 in 60 number rather than the 1 in 200 or 1 in 250 number. But she's skewing her thing because this is what she believes. But the truth is, if a mother is on seizure medication, then maybe giving vitamin K to the baby is a good idea. But that's not why vitamin K is given to most babies. Most babies get vitamin K to prevent what's called late onset vitamin K deficiency bleeding, which happens days or weeks down the road. And that incidence is about 6 per 100,000. Or if you break that down, it's about 1 in 16,000 and change.
Wow.
So what a mother has to decide, well, parents have to decide, is if I'm not on seizure medication or some other medication that may affect vitamin K early on, then is 1 in 16,000 a reason to give my baby something that may or may not be safe? It's got, it doesn't have mercury in it. It doesn't have, aluminum in it. It's got, other chemicals in it and things like that. And it's certainly a noxious stimulus to give to your 1-hour-old baby in its thigh. And the dose is essentially the same whether your baby weighs 5 pounds or 10 pounds, which is I always wonder about that in vaccines when you give the same, because every other medicine you give to a baby is based on its weight, but not vitamin K and not and not vaccines. It comes in an ampule and you just give it. But you have to decide, is the 1 in 16,000 risk worth taking to defy nature's design for the other 15,999? And is there a downside to giving vitamin K? And if nature decided that vitamin K isn't really necessary, then maybe there's a benefit for babies to have, like, for example, but say thinner, more watery blood where it's less clotty blood. And maybe because the baby's still forming neurons in its brain and other parts of its body, and it's got these tiny little blood vessels, they don't want the blood to be sort of thick and coagulate. That's the wrong word. And just coagulate. They don't want that to happen. So maybe nature knew that. So are we altering things? And the question is, has anyone looked to see if there's a downside to giving vitamin K to the 15,999 babies who don't need it? And the answer is, I don't think so. I don't think there have been any safety studies or randomized controlled trials on newborns, some getting vitamin K, some getting saline, and seeing downstream if there's any complications. And now that it's become obviously accepted as the standard of care, anybody wanting to do that will probably not be able to pass human subjects ethics issues. So the studies it's a perfect Mobius strip of illogic that it just goes round and round and round, and you can't do this because it's standard, but we never prove that it's safe, but you can't do it because it's standard, and on the argument goes. So this influencer was being very dishonest in her presentation because she left out the facts that we're not giving vitamin K generally for the general population for early onset, because early onset doesn't affect babies who generally aren't affected by their mother's medication. So that's where that goes wrong. I don't know why they do that. I did not watch any of her other reels, but I suspect that she's like babies after 35 or Paging Dr. Fran. They're all into the medicalized birth model because they really believe it. But they're really being unscientific because the scientific literature is filled with data to support the home birth model and the lower intervention model. And if these doctors that I just mentioned, if the outcomes in their worlds were perfect, or not perfect, nobody's perfect, but great, then they could make an argument that they're doing well. But by every measure, we're not doing any better despite all these interventions. And by other measures, we're doing a lot worse. So why are you defending that system? What's in it for them? And when somebody like this other influencer has 3.2 million followers, how did somebody get 3.2 million followers? I mean, I don't know. Is she that popular, or is she corporate sponsored? I know that I get emails every week from people wanting to sell me followers.
Yes.
Yeah, here, I can get you 10,000 followers for it's like, no, I don't want 10,000 bots following me.
Yeah.
Right. So that's the story on vitamin K. It's ultimately the personal decision of the mom, whether she thinks it's valuable or not. And then, of course, there's no discussion about whether oral vitamin K might be a decent intermediary if you're not sure.
That's what I was going to ask, because that's what my original plan was for my second. Because for some strange reason, I didn't know if they just mischarted it, but in my son's chart, he never received vitamin K. So I was like, all right then, like, let's just go with it for my second. And the residents were so adamant, like, you have to give vitamin K or you cannot deliver here. And I was like, well, I have my epidural in. I'm about to give birth. I'm giving birth here. So I don't want to do vitamin K, but they just pressure you. And when you're in labor, you're in active labor, of course you're going to get coerced into something you don't want to do because you're vulnerable, right?
Totally vulnerable.
But it's strange to me though that nobody necessarily knows why, because I asked them. And I am so big into studies. I love studies. I may not understand everything, but I did my minor in sociology and I had to really understand how to conduct studies and how biased studies can be. And I don't think people realize that there's always something to counter your argument, right? So even if it hasn't been looked at, and I think with pregnancy and babies, it's very hard to because of the ethics committee. Like you can't say, I am going to test this when you can't say for certain that this is not going to harm a child or a pregnant woman. And that's like a big no-no. Like, we're not doing that. We're not going to allow you to do this. And you look at like some of like the Stanford studies, how like horrible that was to be done, but you look at how much education came from it, right? And I'm not saying the harm done was worth it or, worthy of it doing and conducting that experiment, but we still talk about it to this day, right? It's still a part of literature that people look back on.
I would tell people that are listening that you're right. It is very difficult right now to know how to interpret what your doctor's telling you, how to do a Google search, and how to interpret what's a good article, what's a bad article. I can tell you some simple rules. One is when you hear something in the news, don't believe it at all. You have to look into it.
Yes.
Science by press release is not science. So you have to look at the paper that they're talking about or the study that they're talking about. And what you got to do when you look at a paper or a study is not just read the abstract and then the conclusion. You actually have to look at the paper. You have to look at the graphs. You have to read the material and methods section. It's very dry and boring, and most people are not going to do it. So they're just going to read the abstract, which is really a description of what writers want you to believe that they found. But then you find that the methodology was awful, or they only had 12 people in the study or something, but that's buried in the material and methods section. But the headline in the New York Times makes it sound like this is the best thing since sliced bread, which is some of the problems with the things like the term breach trial and the Arrive trial, to name just two very prominent papers that are terribly flawed. We saw papers come out during COVID that said that these medications don't increase miscarriage rate, don't cross the placenta, don't affect a mother's ovaries or father's testicles or anything. That was all a lie. Some of it was outright lying. Some of it because they already knew that it did, and they published this data anyway. Another way to look at it is when you look at it, they're supposed to dictate on the bottom of the paper, does the author have any conflicts of interest? Now, obviously, you can't necessarily trust that they're being honest, but if they say that, yes, I get grants from the NIH and from the Pfizer Foundation, then you take what their science is as a grain of salt, because they're being paid to do something. And if they publish things that show that the product was lousy, they're going to lose their grants. So it's corrupted. And you also have to look at the motivation of the authors. Are the authors benefiting from it? Like when somebody writes a paper that's against the narrative, they're risking their career.
Yeah.
Whereas someone writes a paper that's with the narrative, they will likely get promoted. So that kind of science, if it's with the narrative, you have to be more skeptical of. You just have to. And people that I see, like the American College of OBGYN, and I don't know about the Society of OBGYN in Canada, but they outright lie. Their latest thing, that the meme that came out this week was that, did you know that you can get your Tdap, flu, COVID, and RSV shots in pregnancy all at the same time?
Wow.
This is in one of their memes on Instagram. People can look it up there at acog.org on Instagram, and they can go through their memes, and they'll see some of the most obtuse, sometimes corrupt memes that you've ever seen, and they seem to be proud of them. And I don't quite get it. None of those vaccines have ever been tested for safety in anyone, let alone pregnant women, and certainly none of them have been tested for giving them at the same time or the potential cumulative effect. As a matter of fact, right now, my friend Paul Thomas and another guy are suing the U.S. government because there are no safety studies or long-term studies on the cumulative effect of giving your children 72 vaccines.
Yeah. And I think sorry, go on.
No, I was going to say, when I was a kid, I can only remember getting 2.
Yeah.
I missed the smallpox era because I don't have the thing on my arm. And I got polio, oral, and I would get a tetanus shot once a year. And I had measles, and I had mumps, and I had chickenpox, and I had German measles. And I think my immune system is obviously better off for it, that I had all those so-called childhood diseases, which, yes, every now and then someone will die, and it's horrible. But when you're it gets back to the whole messing with Mother Nature thing, thinking that we can do better. Now, if you have a terribly lethal disease, and you might be able to get something that might protect you from getting severely sick or die, that makes sense. But measles and mumps and rubella and stuff, that's not it. I mean,
So
all you do is look at those. One more thing, you look at those graphs in the books, and you see that the rate of dying from that was down to like less than 1% before the vaccines were even introduced.
yeah, so that's what I was gonna say is like when you look at data from before vaccines and after vaccines, I don't feel like it's necessarily telling the whole truth because you're not looking at every causation. Like, where did these people have underlying health diseases? Did they have immune issues? Like, I think that that's the thing that's hard is that the general public doesn't understand necessarily how broad studies are, and they cannot look at every single factor in a study. Like you just can't do it, right?
No, they can. And by the way, I mean, I think everyone listening is in agreement, if they're reading any literature at all, that the rate of chronic illnesses in children and adults has never been higher.
Yes.
So if you're already starting with a baseline population that has more chronic illness and you're giving them more toxins, wouldn't it be natural to expect, or maybe you're letting them catch a disease that normally a healthy person would just fight off. But now, because you've made them chronically ill by giving them toxins throughout their childhood, that if they do catch measles, again, it probably vaccine strain measles anyway, because they got it from somebody who got vaccinated. Maybe we're doing something that's not quite right. Maybe we should rethink our process. There are families out there who, when there's a newborn baby, the couple is so sort of, brainwash sounds terrible, but they're so committed to the idea that vaccines are so good that grandma can't come visit their grandchild because she hasn't had a DTaP shot. But people who get a DTaP shot are more likely to be shedding pertussis, or if they get an MMR shot, they're more likely to be shedding live strain measles that the baby will catch than somebody who has had pertussis or has had measles and has natural immunity. But the ones who are not getting vaccinated will be excluded from visiting the new baby.
Well, the one thing that I found interesting was that you actually can lose your immunity through pregnancy. So I don't know if they do this in the States, but when I was pregnant with my first, they tested all my immunity to vaccines, and I wasn't um, immune to a few different vaccines, and they pushed it on me. So as soon as I delivered my baby, 12 hours later, they come, they're like, "We're here for your vaccine." And I'm like, "What do you mean?" And they gave me MMR vaccine. And you just say, okay, like you don't really think anything of it, but they just tell you. But like I'm pretty sure when you're immune to something, like if I got the chickenpox as a kid, you usually keep your immunity, right?
Yeah, for most of your life, you're immune. I mean, you're not immune from getting shingles at some point, maybe, but yes, for most of your life, you're immune. What you're saying is so true. When I was a resident at Cedars, and in the years that I worked there, and I'm not just picking on Cedars, it's just what I know. On the standing order sheet, postpartum was if on her prenatals it said she's rubella non-immune, we were encouraged to have the woman take the rubella vaccine, which I think was probably always the MMR, because I don't remember when rubella was just rubella. I don't think you could just get a rubella vaccine. So we were giving pregnant women MMR vaccines postpartum, and against the disease they probably had as a kid, and at a time where they're breastfeeding and doing all these other things. What are we doing? Why are we doing it? And the cynical me says they've got a captured audience. Let's get it in you now. Let's give it to you at the hospital because that's a new RVS code that we can bill for. If we don't do it at the hospital and you go to your doctor and you get it at your doctor's office, then we've lost that revenue. And you have to understand that this may sound cruel, but this is how hospitals think. Hospitals need to keep their doors open. They need to generate revenue. That's, jokingly why an aspirin costs $70 or something like that. Nobody pays that kind of amount, but that's the kind of shenanigans that go on behind the scenes, and everything has a code. And the more you do, the more the hospital makes. And I don't know that doctors are incentivized to do that, but I do know in some health systems, and this is going to shock some of your listeners, that my salary next year is based on what I billed this year.
Wow.
So the more things I do, the more ultrasounds I order, whether they're necessary or not, the more labs I draw, whether they're necessary or not, the more studies I order, whether they're necessary or not, that generate revenue for the hospital, that influences my salary next year. Talk about ethics. It's kind of like we all have heard that pediatricians get paid incentives or bonuses depending on the percentage of children in their practice that are fully vaccinated, which is one of the reasons why practices are kicking out women who choose not to vaccinate their children. Not because they're so worried that those unvaccinated children will infect their waiting room, but it affects their bottom line because it affects their percentage. Like if you're at 74% and you get a big bonus at 75% and you kick out 3 people that don't take vaccines, suddenly your percentage went up to 76%. You get a bigger bonus. So why would you keep them in? You make more money off the bonus than you'll ever make off of a woman who doesn't want her child vaccinated, because vaccine revenue is the heart of pediatric practice.
Yeah, I've always wondered that. My brother always questions it too, like when they order ultrasounds or x-rays or, like how it works here, because it is technically like a universal healthcare from the government. But like, do they get kickbacks? Do they get incentives? Like, what is it? Because no doctor will just openly state, yeah, this happens or it doesn't happen.
I don't think in the system like yours that the doctors' salaries are based on their production. I think that's more in an HMO, free market system like we have here in the United States. But the hospital makes more money, or the radiology group makes more money, and they're covering their butts. They're not concerned that the test has any downside. They're not concerned that an X-ray or an ultrasound while you're pregnant may have negative effects on your baby. I mean, they may be concerned, but that necessarily it's a financial interest for those doctors. I think that the system benefits from it, and I think that they think it's less liability. And by the way, a lot of times they do things not because they're even thinking. They do things because they're following an algorithm.
Yeah.
Like all mono-di twins need to be delivered at 37 weeks. All di twins at 38 weeks. All diabetics at 38 weeks. All diabetics type 1 need to have antenatal testing beginning at 32 weeks. Do they really? Are all women labeled diabetic exactly the same? I mean,
Yeah.
that's a foolish premise, and yet
So
it runs the process.
in the States, is it the same kind of thing where women get tested for GBS? They have to do Tdap, they have to do Strep B. Do they all get tested like that? Is that like a universal thing around the world, you'd say?
Well, they're all offered testing, and most women don't know they have the right to decline. So yeah, most women are offered GBS testing, sometimes in the first trimester now in the urine, and then in the third trimester in our country. Now, most countries around the world have given that up, and they don't screen for GBS anymore, because GBS is about 15-20% of the population are colonized. It's transient, it comes, it goes. All that tells you when you put the Q-tip on the cervix or in the vagina is what's going on in the vagina at the moment the Q-tip was in the vagina. It doesn't tell you what's going on an hour later or 2 days before or whatever else. So it's kind of a foolish way of doing things. And then if they test positive in my country, they're recommended to get antibiotics in labor because, again, the medical model doesn't think there's any downside to giving antibiotics right and left. But a baby that gets group B strep and gets really sick can get really sick and can theoretically die. And it's a horrible thing that happens. But again, we need to know what the number needed to treat is. How many babies that are normal need to get antibiotics to prevent one bad outcome? And what are you doing to all those babies who didn't need it, but you gave it to them anyway to prevent that one bad outcome? And clearly we know that we're affecting their microbiome. So European countries will treat based on symptoms. If you premature rupture of membranes for a prolonged period of time, if you have a fever in labor, if your baby's fetal heart rate becomes tachycardic, then they will offer antibiotics, but they don't routinely give antibiotics anymore. And their outcomes essentially are no different than ours as far as babies dying from group B strep.
Yeah, that's what I was going to say. Like, is there something that is like a telltale sign that they should be giving it? Because, for example, my son, as an infant, had C. difficile 3 times, and nobody knows how he got it. we didn't get it. Parents didn't get it. Nobody got it. But I was in the hospital for 4 months in and out on antibiotics, IV for over 70 days, oral antibiotics for probably 30, 40 days. And I had GBS positive. So I had antibiotics through my
Mhm.
IV when I had a delivery. And, he was pooping 18 to 20 times a day for 6 months, and then it completely stopped. And nobody could figure out why. Everyone's like, oh, it's normal. He's breastfed. Don't worry about it. And then he finally wasn't going for over 14 days at a time. And then they finally did testing and realized he had C. difficile. And even my OB is like, this is so strange. I've never seen it. And my first question was, could it be caused by the antibiotics? And his thing was he's like, I have no idea, but I'm not saying it's not a thing. And I was super lucky with my OB. And even with the COVID vaccine, he told me, because I had issues with my kidneys, he's like, why are you going to add something else into it? Like, yeah, maybe the government and stuff is saying you should be getting vaccinated, but if I'm not telling you what to do, but I wouldn't do it if I was you. So I had somebody who was not biased against the system, I would say. Like even when I wanted to be induced, he was super kind of like against it. Even they wanted to put a PICC line in me for my IVs, and he was like, why would you do that? Like there's just so many more issues that come with every procedure you're doing. So I was lucky in that sense that I had him as my doctor, because I always think if I had somebody else, I probably wouldn't have ended up the way that I did.
I agree with you. He sounds like a really good guy.
Yes.
And again, I'm not here to berate my colleagues. My colleagues need to wake up. But C. difficile in an adult is almost always a result of prolonged antibiotics.
Right on. And
So,
hospital settings.
right. So the fact that your baby had C. difficile is, I mean, I don't even know why they're scratching their heads. Right. You got all these antibiotics. Your microbiome was completely altered when baby came out. You were on antibiotics when baby came out. Right. So the baby had
Yeah.
antibiotics on board in its system. So even if it was colonized with some of your bacteria, it might very well have killed them off, and then was colonized with bacteria from other parts of the hospital or the nurses or the nursery or, who knows what, but wasn't colonized with the proper bacteria. So sometimes it's really interesting that the doctors often live in denial that much of what they're doing is iatrogenic harm. But when you've done what I've done, which is spent 28 years in the hospital system and 12 and a half years in the home system, you actually have a comparison, because most practitioners live in silos. The OBs that work in a hospital have never been to a home birth. How do I know that? Because even after 28 years of backing midwives, when I finally left to do home birthing, I had never been to one.
Oh, wow.
I had never gone when I was backing midwives. They probably invited me, and I probably just didn't feel like I wanted to go or whatever else. I know for a fact that I've invited, and I know many midwives I know have invited some of the local docs that we like to come to a home birth, and they're just like, "Ooh, I don't want to do it." No, just come like Uncle Bob. You're not there as a medical person. You're not taking any liability. Oh, I don't like my malpractice carrier would like that, or my boss would like that. I don't think I'd do it, or I don't have the time, or they don't want to be up at 2 a.m, which is when most women are in labor anyway. So they stay in their silo, and as long as we keep the silos walled off like that, we're never going to have an understanding of what's going on. One of the nice things that I would love to see happen is I'd love to see OB residents get to spend 2 months or 3 months with a home birth midwife, and I'd like to see home birth midwives come and spend some time in labor and delivery. If there's credentialing issues and stuff like that, okay, so they're just observers, and they have to get a consent from the woman, but let the midwife just observe how the hospital does things, and vice versa. Let hospital nurses and hospital doctors come to, in collaboration with some local midwives, come to some home births and see how it's done and see the differences. And maybe there'll be less fear and anxiety and less fear mongering about, well, what happens if you start bleeding, or what happens if the baby does this or baby does that? Well, when you don't mess with Mother Nature, like what hospitals do, which is essentially immobilize you, interrupt you, starve you, medicate you, numb you, all those things, you don't generally see the rapid deterioration of the baby's fetal status that you would see in the hospital setting, where they do an emergency C-section because the baby wasn't tolerating the numbness from the epidural and the lack of calories the mother hasn't had in 20 hours, and the hyperstimulation from the Pitocin, and the baby's heart rate goes down, and they do a C-section. They say, wow, what would have happened if this had happened at home? It's like, are they that obtuse? They don't understand that when you don't mess with nature, those things rarely happen. And maybe part of it is that they only see the outcomes where there is a problem at home sometimes. And so they have this, proctologist view of home birth.
Yeah.
Yeah.
And I don't know if I'm biased to this, but I truly think that when you are scared medically and doctors who you think know the best, which I mean, in society, you definitely think a doctor who went to school knows better than you, right? Like it's just a common thing. You start to think that, okay, if something's going to go wrong, I need to be in the hospital, right? Like I don't want to even chance it at home. And even with an epidural, like I don't really know people who are like, oh, I want to get the epidural 100%, but then you start leading up to it and you're like, oh, I'm for sure getting the epidural. Like at first, before you get pregnant, a lot of people that I know, they see that needle or like, I'm not getting it. And then as it goes and goes, they're like, okay, I'm getting scared. And the other thing too is I don't think women speak about birth. They either say, I have a good birth, I had a good birth, it was great, whatever, or I had a bad birth, but nobody asks why. Why was it bad? What went wrong? What do you think went wrong for it? And I don't know if you can, talk on this or not, but I think a lot of times when people have issues in their prenatal period, so whether that be financial stress, relationship stress, even the like COVID, like that put a lot of stress on a lot of people. Like I think that does not equal great outcomes to postpartum periods, to birthing, to all those different things.
No, and if I could even refer to Michel Audin, who passed away, he was a pioneer in the idea that women should birth by themselves. They should birth alone. He didn't even believe that the partner should be there. And he's right, technically. I mean, obviously, we live in a society where some of the strongest bonds you can possibly have are to have your partner there supporting you and catching your baby. I've said this many times, so the man who supports his woman, who catches his baby, who is there for that whole process is much more likely to be a good husband and a good father. Do I need a study to prove that? No, I don't need a study to prove that. I can just tell you that that's the case. But Michel Audin is onto something, because in nature, and again, we're mammals, and in nature's design, if we go back and think about how mammals give birth, they go off to a quiet place, they go by themselves. And as Sarah Buckley is famous for saying, they like it to be safe, quiet, and unobserved. That is ideal. They don't want to have their cortical brain involved. When you bring in fear, you bring in the fight or flight response. What happens then is you secrete adrenaline and other things which cause your labor to become dysfunctional. And the mammal tends to get up and then run away. And only when it's safe will labor ensue. This way, nature ensures the best chance for survival. So what we do is pretty much antithetical to all nature's design. From the moment that you get in your car to drive to the hospital, to the moment you put your baby in the car seat, everything is done. It's antithetical. We need to remember that birth is a sacred process that's designed by nature to work well most of the time. And how a woman feels about herself, her partner, her child, her life, is often dictated by how they were treated and how they experienced birth. And, we talk about, a third of women have birth trauma. I would tell you it's a lot higher than that. Most people don't they consider trauma to maybe be too harsh a word. But it affects your sovereignty to lose control of the process and surrender it to a third party who doesn't really care about you. And especially in today's system, in the midwifery system, you very likely have a midwife that's going to be your midwife throughout your entire pregnancy. And unless she's on vacation or something like that, you're likely to have her at your birth for the entire time. That used to be true in the medical system up until the 90s, when managed care came in, and doctors no longer were independent practitioners, but became employees. And as I said earlier, they're making a salary, working a shift. And so now a woman may go to an obstetrical practice and see the same doctor for most of the visits, but there's 7 doctors in that group. And so that woman has a 1 in 7 chance of having the person that she feels comfortable with and knows really well, which again makes her feel safe, where you labor better when you're safe. That 1 in 7 chance of having that practitioner, and 6 out of 7 chance you're going to get a stranger. And then what makes it even worse is the nursing staff who does most of your care. You don't know any of them. You meet them in the middle of a contraction and they say hello and you get to know them and maybe you get to like them. And then 7 o'clock in the morning rolls around or 7 o'clock in the night rolls around and it's change of shift. And now suddenly the person that you got to know over the last 7 or 9 hours is gone. And then now another stranger walks in. And this is the system that's designed for the system. It's not designed for the pregnant woman. And if risk managers and if administrative people really were intent on doing what their PR departments advertise on the radio, then they would change the way they would change birth at all. They would have continuity of care. Australia is working on a project like this where they're having, I forgot the name of the project now, I knew it, but where they have continuity of care. And the midwife that you see during your prenatal care, even if it's a hospital birth, because midwives can have privileges in most hospitals in Australia, that's the person that's going to be taking care of you. And they're looking at outcomes and they're seeing the outcomes are better. They're simply better when there's continuity of care and when a woman feels heard and safe, then nature will allow labor to progress the way it's supposed to. And you're far less likely to have an obstructed labor, a postpartum hemorrhage. When there's patience, you're waiting for the placenta to come out. You're not pulling and tugging on it because, again, you have to get to the next task. You have to go to the next room because there's another woman waiting for you to go catch her baby. So when you do that, it's just common sense that you're going to have better outcomes. And there's massive papers that show that with similar cohorts of women, pretty much outcomes in pretty much every category, from patient satisfaction to less episiotomies, to certainly less surgical or operative births, to better bonding and better breastfeeding, are better in home birth than they are in the hospital birth.
Well,
And
it
birth,
makes total sense. It just, like, when you look at having somebody who has continuity of care, like I had an amazing OB. The only times things went wrong was when I was in the care of a different OB, and I never had my OB deliver either of my children. And I swear that that is why I had issues. And I don't know if this is the same in the States, but I have teaching hospitals where I am. So I had almost only residents looking after me. And I had a very big altercation with a resident when I was maybe 30 weeks pregnant with my second, and I had endless issues with my kidneys once again, but I refused to get morphine, which they kind of kept trying to push on me, and taking more antibiotics. I wanted to go home, and she said that my baby would die because my uterus would explode because my bladder would explode. And I remember at that point, I was like, no residents on my care. I refused for it. My OB agreed with me. He actually put in a complaint. We were supposed to go in front of a board. Then I had another mishappen or another issue mishappen. But I swear that if I had my OB from the very beginning of my pregnancy to the very end, none of it would have happened. And I will die on that tree because I genuinely believe it.
well, I'm sorry that happened to you, Kia. It hurts me when I hear you tell that story. I mean, that resident was just regurgitating information that somebody had taught him, and he or she was not thinking. Clearly, he did not look at you as an individual. He did not want to. Probably didn't have the time to sit on the end of the bed and hear your story. I suspect that they were in, they were out, they're doing their rounds, that sort of thing, because the system isn't designed. People listen. The whole idea that you go to a hospital and put on a hospital gown and get blood drawn implies that pregnancy is a medical problem. It's the same questionnaire and the same procedures you would go through if you're coming in electively to get knee surgery or your gallbladder removed or whatever. That's how you're treated. One of the things that I remark upon a lot is when you go to a hospital and you go to a labor room, the center of the labor room is the bed. Well, patients go in beds. That's what hospitals do. Go to a home birth, and how often will you find a woman laying in bed? Almost never. She might be leaning on the bed, or she might be on all fours, or whatever, but she's usually in the bathroom, or she's in the kitchen, or she's pacing, or she's out in the backyard walking around. She's not in the bed. But the hospital, you walk into any beautifully designed LDR where they made nice hardwood floors and curtains to make it more home-like, because that's the way administrators think when they wanted to make hospitals more home-like. It didn't mean treat them like they are at home. It meant hardwood floors and curtains. They don't have a clue as to what they're doing. I don't know how people get in charge of things sometimes. Sometimes you think the worst people rise to the top. There's the old saying that them that can do, them that can't do teach, and them that can't teach administrate. And I really believe that that's what's going on, because nobody who goes into medicine wants to become an administrator.
Yeah.
They want to do it. So what mindset wants to become an administrator? And then, they're under the auspices of the risk managers and the board of directors and the medical executive committee of the hospital to protect the hospital's ass. So the policies are there to protect the hospital, not to benefit the individual woman who's coming in labor, because labor is not an illness. Labor is like breathing or digestion. It's a normal bodily function. It's reflexive. You don't think about it. You're going to conceive, grow a baby, go into labor, deliver a baby without thinking about it. When you start thinking about it, like with breathing or digestion, you can screw it up. So you can hyperventilate. You have to give a speech and you get diarrhea. You have to go to court and you hyperventilate. That's your higher brain screwing up functions that fortunately you and I don't have to think about. Same thing with pregnancy. It is not an illness, yet the minute you walk into the hospital, you have to have a wristband. You have to have an IV. You put on a special diet. Again, you change into a hospital gown, which signifies what? That you're a patient. Why do I have to wear a hospital gown? Why can't I just go naked? Why can't I just wear my own jammies? Why can't I wear my yoga pants? I mean, I don't whatever you want to wear. Because the mentality is to get you to submit, to give up your autonomy, and to put them in a position of authoritative knowledge over you. And there's a thing called the medical gaze, which I learned from my friend Melanie Jackson in Sydney. The medical gaze is very interesting. The medical gaze is when doctors hear your story. What they're hearing is the pathology. They're hearing that Kia is pregnant and Kia has a kidney infection. And their focus doesn't become Kia anymore. It becomes Kia's kidneys.
And we are going to pause it right there. So stay tuned for part 3 of this episode next Sunday, 8 p.m. EST.